I would like to formally welcome you all to the ArcFest, particularly now the Shara from Liverpool's turned up. Dorcas, when you're ready, please do come up and join us on stage. So, today we're going to focus on how, as a collaboration, we're working together to identify and tackle health inequalities that face our region, and complementing the strategies of our two local integrated care systems. Their role includes providing stronger foundations for collaborative working across the NHS, local government, social care, public and voluntary sector partners, and the broader agenda of prevention, health inequalities. And therefore it places the ARC really in a really strong position to work with the ICBs on that task of identifying the research that we want to do and the research that others are doing, and how we can help answer those key questions and also put those answers into practice. We have two integrated care systems, NHS Cheshire and Merseyside, and Lancashire and South Cumbria, which have an integrated care board and a health and care partnership. And we're going to be hearing from them in a couple of moments about their regional strategic approaches. We also have a panel on stage featuring representatives from organisations and other guests from our membership and public advisors who are active in our collaborations. So let me introduce Dr. Greg Irving from Edge Hill University, who's an academic GP like myself, and he works as a GP in St Helens, and I think we worked together for quite some time. I'm just going to go through the panel, Greg. You can hold fire for a sec. And he's representing NHS Cheshire and Merseyside Integrated Care System. He's one of the research directors. Dr. Sakthi Karunanit, sorry Sakthi, I should have checked that before. Well, that's what it says. It's not. It is Karunanit, isn't it?
Karunaniti.
Karunaniti. Oh,
yeah.
Sorry, the I's missing at the end. I'm really sorry about that. I'll add it.
Okay.
So Sakti's the Director of Public Health for Lancashire and South Cumbria, for Lancashire, and he chaired the Joint Intelligence and Planning Group to support the management of COVID-19 as the pandemic spread across Lancashire as part of the Lancashire Local Resilience Forum. And Sakthi and I have been working together in what was the STP before it was disbanded as COVID came along. And I know that Sakthi is a huge champion for prevention. And whenever we did anything, we just look at Sakthi and say, so, apart from prevention, what else are we doing today? So I'm looking forward to hearing from Sakthi about what they've been doing. Both the ICBs did a lot of work looking at health inequalities across their region. Dorcas Akeju is one of our public advisors. She was born in Nigeria and has lived in Liverpool since 1974. She trained as a midwife at Liverpool Maternity Hospital and she practiced in both hospital and community settings for 35 years. I don't think we're expecting any births today, but it's good to know you're here, Dorcas, just in case. Professor Joe Blair is a member and co-lead of the ARC North West Coast, works in the theme with me in health care across the life course. She's a consultant endocrinologist at Alder Hey Children's Hospital in Liverpool and is an honorary professor at university. And she's one of our professional co-leads, and Dorcas is one of our public advisor co-leads. Each of our themes has academic and public advisor and professional leads of the theme. So, the panel today is to talk about and facilitate discussion between us as an ARC and the ICS in their strategies, help us identify where the collaboration can help us work closer together, and help us and them deliver our aims together. And today is a forum for that feedback about what they're going to present and how that relates to us. So please do ask questions. I don't want lots of really awkward silences. In the wider room, we have representation from ARC members, including the NHS organisations, third sector, local authorities, universities, public advisors, all of us working together on the ARC programme and to support the delivery of the integrated care system plans. Our members have a key role to play across our work as well as supporting integrated care systems. They have a huge challenge on their hands. You may have noticed that the NHS and social care is under a bit of pressure at the moment. No pressure, but it's your job to sort it out, apparently. And that was yesterday. But we really, I hope, can move forward together strategically. So At 11:15 or early, if we get time, we will put a spotlight on some projects that we're doing, as I've said, and we'll be offering colleagues to present some of those work. But first, I'm going to invite Dr. Greg Irving onto the stage to talk about what's happening in Merseyside and Cheshire Integrated Care Board.
Thank you, Mark. Good morning, everyone. Greg Irving, one of the directors of research for Cheshire and Mersey ICS, and this talk's going to focus very much on tackling inequalities. Just a quick overview of the Cheshire and Mersey ICS. It's the second largest ICS in the country. There's about, I think, 2.8 million people, and it's an incredibly complex system. As you can see, there's 9 local authorities, 18 trusts, 2 provider collaboratives, 51 primary care networks, 350 GP practices and 1,300 care homes. So it's a complex system. Back in 2022, a review was undertaken by Sir Michael Marmot, and an altogether fairer report was produced that followed with a keynote address, and it was actually picked up in the national news. Essentially, there's a long-standing history of challenges from a health inequalities perspective within the region, and there was a clear need to identify what areas needed particular focus and what the current challenges were. So from the altogether fairer report, Sir Michael Marmot and his team identified a complex system of beacon indicators of areas that needed these were developed in consultation with hundreds of individuals from across Cheshire and Mersey, so definitely meeting that challenge of being co-produced. And these were, if you ever get a chance to look at the report, the back end of the report, but they're really worth looking at. The very upstream, as Michael Marmot said, they're very much focused on the causes of the causes and some of the challenges that need to be addressed. So do have a look at those beacon indicators. But essentially, there was a response from the ICS in relation to that altogether fairer report. And it was recognised it was an extensive and comprehensive review, and it was pretty groundbreaking in terms of setting the agenda on health inequalities across Cheshire and Mersey. And it was identified some of the key points of action that were needed. And it was highlighted there was not one single thing that would reduce inequalities, but it was action on multiple indicators that was going to be necessary. So there was the need to take that programme forward and come up with some action. As I say, I would strongly recommend that you have a look at that indicator set. And that set is now live within, many of you are familiar with the CIFER dashboard, the Combined Intelligence for Public Health Action. That beacon indicator set is currently live within the CIFER programme. I won't go through all the indicators, but some of the key themes that came out from that were giving every child the best start in life, enabling all children, young people and adults to maximise their capabilities and have control over their lives, create fair employment and good work for all, ensure a healthy standard of living for all, create and develop healthy and sustainable places and communities, strengthen the role and impact of health provision, tackle racism, discrimination and their outcomes, and pursue environmental sustainability and health equity together. So there's a need to act on these different areas, and you might find that some parts of the system are better suited to addressing some of the indicators, and other parts of the system are better at tackling others. But these were the key themes that came out. So in terms of the recommendations that came out of it, it was to increase and make equitable funding for social determinants of health and prevention, strengthen the Partnership for Health Equity, create stronger leadership and workforce for health equity, co-create interventions and actions with communities, strengthen the role of business and the economic sector in terms of reducing health inequalities, and extend social value and anchor organisations across the NHS, public services and local authorities. And finally, develop social determinants of health, includes action on the social determinant of health in all policies, and particularly with a focus on those beacon indicators. So that's as close as you get in terms of like an official response from the ICS as it currently stands. In terms of the organisation as it's been set up, if you look within the purpose of the ICB, if you look towards the right-hand side, you'll see that tackling health inequalities in outcomes, experience and access is one of the key purposes that the ICS actually exists. So it's actually written directly in terms of its reason for existence. So it's of central importance to what's happening within the ICS. Oops. Hot off the press, the ICB have just been looking at developing a clinical constitution for the ICS, and if you look within it, particularly in the first panel, at the bottom column, in terms of the pledges that have been made, that there's a very strong focus on research, and within that includes tackling inequalities once you bring that purpose on board. So when any care pathways are being developed or looked at and considered, research is a fundamental part, and there's been a strong pledge from the ICB in terms of responding to that. Has anyone come across this document so far? This was the guidance that's been set out by NHS England in terms of when the ICBs are putting together their research strategies. This is the guidance that's come from NHS England. So it's an overview of the responsibilities that will be needed to be put in place. And I spotted this amongst the legal requirements, and that is that the ICBs will have a responsibility to act to reduce health inequalities. So it's going to be a statutory obligation that the ICSs will need to address health inequalities. I won't go through the whole document, but I have picked out some of the key points that will be needed to be addressed when the ICS develops its full strategy. But essentially, that's one of the key points is to identify and address local research priorities and needs, and work collaboratively to address national research priorities. So as Mark's just said, there's a strong commitment to working with this group and with others to identify what those research priorities are. One of the key steps that we're looking to develop is going to be an integrated research and innovation system. So within that, that will involve looking across the system, everything from social care through to secondary and tertiary care. So looking at developing a research strategy that works across the system, looking at where the current friction exists within the system and where that can be improved. And to help steer that, there's going to be the steering committee formed, and ARC will be one of the key partners that's involved in that. So we're here today. We want to listen to what you feel are the priorities in terms of research, and they'll be very much help to develop that strategy. Just some examples of some research engagement work that's gone on. So I've flagged up the ICS REND work, which stood for Research Engagement Network Development Programme. And there's been funding locally, collaborative projects that were for 4 months, funded by NHS England to help reduce inequalities. And I think 100k was given to 2 sites within North West, and it was awarded to 2 voluntary community or social enterprises to help build some capacity to engage engagement work. So I think one was given to Liverpool and one was given to Morecambe Bay as well. And they were the Kickstart projects, and I believe those 2 projects are then going to be invited for to apply for stage 2 funding as well. So there's opportunities there already for funding that's going to be coming from NHS England. I should say that work is very much aligned with the Core 20+5. I don't know if everyone aware of this programme. So yeah, so that's another thing. If you look within the document on maximising the benefit of research, the Core 20+5 theme is very heavily integrated in terms of the guidance that's been put there. So in summary, there's a need to, we're looking to develop our strategy. We want it to be, as we've said, focus on this integrated research and innovation system. We very much want to engage with ARC as to help with steering the strategy as it evolves, and we're here to listen today to what you feel the priorities are. Thank you.
That's great kick-off. Thank you very much, Greg. In fact, looking at that slide, come back to that if we can later, of the guide to research, because I thought that was an ARC slide. We're so closely aligned with what we're trying to do and what you're tasked with doing. So it's very great to see that. So I'd like to please invite Sakti Karunaniti to the stage. Now I've got it spelt right on my slide. It's much easier. You can come here. I know. I'm really sorry about that. It was spelt wrong.
There's nothing to apologise, Mark. It's a teachable moment, as my teacher used to say. For all of you, by the way.
Cabbage and garbage.
Yeah. It's a real pleasure to be here. Good morning. I can see a familiar face in that chair, and with that chair, but there are lots of unfamiliar faces to me. So I'm Sakti Karunaniti. I'm going to ask some of you during the break to repeat my name. I am currently working as a Director of Public Health in Lancashire County Council, and I'm also linked in with the ICB and ICS. Now, I want to start there. We often sort of conflate these two. Integrated Care Board is an organisation. It's an NHS body that's responsible for allocating NHS resources to improve mostly healthcare, but could be improving health as well. ICS is an integrated care system. So that is a system of organizations, a network of organizations, including local authorities, voluntary community faith sector, and wide range of stakeholders and partners, including higher education institutions. So I just want to highlight that in the new landscape, if you really want to improve health inequalities or reduce health inequalities, to be specific, it's the system level that we need to act, not just one organization, which is the NHS board. The second point, just again, on the same vein as the ARC priorities are laid out, and thank you to Greg. I don't have slides, but I want to just highlight a few points. And Greg covered most of the complexities in the Northwest generally, but particularly in Cheshire and Mersey side, and that applies to Lancashire and South Cumbria as well. But I just wanted to also extend that in thinking, I think there is very little doubt in this room that improving clinical services will not necessarily improve health. We can have a debate. In the same way as most of us believe that improving clinical services won't be improving health on its own, improving health on its own will not reduce health inequalities on its own. So if the ultimate objective is to reduce health inequalities, it's not sufficient to do research on clinical services and to do research on how to improve health outcomes. We also need to really spotlight our attention on how to reduce health inequalities. And by that I mean working in the interface between the political landscape, which determines a lot of determinants of the health, from education to environment to economy, housing, transport. And that interfaces with clinical sciences, broadly speaking, and also the leadership practice. You can have political will and the scientific knowledge, but if there is no leadership, they will fall apart. And if you have the leadership, but we're not accessing the science, then we're just blowing in the wind. And that's where we see, from a local point of view, the real opportunity and the strength of connecting ARC with the machinery that is in the system to start moving some of the cogs. And those cogs are broadly laid out in our system in this way. There is a huge focus on engaging, listening to communities and people. And particularly since the pandemic, where we've really shockingly unearthed the wide-ranging structural inequalities that exist. So that's the first and central piece. You will find a lot of engagement through lots of ways and channels and forums, and we are trying to join them all up in a way as well as the first sort of piece, the cog. The second one really is about the clinical leadership, the clinical assembly, the care professionals assembly, and that is the implementation of the clinical and care professionals leadership framework, which is again a national expectation that systems take that seriously. And in our patch, Lancashire South Cumbria, it is evolving. So there is already, Mark is linked into that, and many of you may be linked into that already. If not, that's another key domain where the plan, the 18 months plan and the future plans need to be socialized and owned by people here in that clinical care professionals assembly. And then the third piece is a really important piece when it comes to reducing health inequalities. And it is less to do with the NHS and more to do with the rest of the system. But the NHS is the bridge that connects a number of these pieces. And by that I mean at a place level, so you've got the system, which is Lancashire, South Cumbria, Cheshire and Merseyside, and then there's another geographical spatial conurbation called places, which may not be directly visible to some of you if you're just looking at it as a whole system. So in Lancashire and South Cumbria, we have at least 5 places. So that is the local authority footprints, broadly speaking. But there is even more complex, and I really encourage all of us to really understand that third cog, which is the place cog, where all or most of the determinants of health inequalities play out, ranging from housing, transport, income, welfare benefits. All of that determines one's health, and also it is really important to reduce inequalities. So that landscape is something that really is evolving, and therefore it's a really good time for embedding research and innovation capability building, especially given Greg's slides about the expectation nationally. There's an opportunity to lock them in, and that's something I wanted to highlight. And then coming to some of the priorities that our local system in Lancashire South Cumbria is working on, very similar. We've had a moment review. We are really driving the core 20+5 in the most deprived neighbourhoods on all those domains. We are also at a place level embarking on, and this is really different in Lancashire South Cumbria compared to GM and Cheshire and Merseyside, because they have elected mayors and we don't. And there's a connection between the levelling up missions, and if you look at the 12 missions, the national missions for levelling up, all of them directly speak to reducing health inequalities. They may not have the label, but they all have the actions. And I would challenge whether there is enough research, whether there is enough dialogue and understanding of how they actually are set up to reduce inequalities. So in a place like ours, that is a key forum for linking research agenda and giving that intelligence and the drive to shape policies at a local level. So that's the 3 big cogs in our local system. Huge public engagement, involvement cog, clinical care professionals, leadership agenda, and then the wider determinants, which plays into programs like the levelling up missions. And in a Lancashire context, there is a political consensus about Lancashire 2050. So it's a 30-year agenda to improve life chances for everyone. That's literally what it says, improve life chances for everybody, regardless of their background and their life circumstances. So that's how the local system is set up. I think we have a huge opportunity in connecting these up with NAHR ARC and other programs reducing inequalities. There are 3 specific challenges for us locally in Lancashire South Cumbria. The first one is the capability capacity challenge. If you scan the Northwest and the academic centres of excellence and the capacity in terms of, I mean, just to give an example, professorial posts directly linked to research, you'll find per capita we are not strong in that sense. And that is a catch-22 situation for places like Lancashire, South Cumbria. The second challenge really is, although we have got a huge emphasis on engaging our residents and communities, there is a huge, still a challenge about making sure that the diversity of our communities is addressed, particularly in participating in research. I think there's a national issue as well, but more so here, I would argue. And the third one, and this is a bigger one, it's a challenge about how we connect research priorities with resource allocation. So there's no point in undertaking a lot of research if we know for sure that domain of work is not coming up for a resource allocation conversation, at least in the next 5 years, 10 years. And there may well be a need for understanding how we set the areas of prioritization for research in line with what's coming up for change, as in the wider resource allocation decision-making domain. And those are my key points from where we are in Lancashire and South Cumbria, setting the scene, identifying that 3 big domains of COGS, as I understand it: public engagement, clinical care, professional leadership, and the wider political system, and trying to align our research and development agenda. We do have certain challenges which I've outlined. Very, very happy to take questions, speak to people. I am one of the many in the system that really are wanting to get behind this and get new knowledge, yes, diffused across the system. Thank you.
Thank you, Dr. Karunaniti. Just embarrassed. Dorcas and Joe, would you like to make any comments before we move to the floor?
To be honest, thank you so much. Is this working?
Yeah.
Yes. I've listened to the 2 doctors, really, and I'm speaking as a public, a patient here today, right? And I know about Mama's Review, and when I was asked to come on the panel, I read it again. 2010 was the review. At the same time, it's race equality as well. And all till now, we haven't really made an end, have we? But for me, we're talking about inequalities. What about inequities? We have to focus on both, really. Because when you're talking about inequalities, that is, there is services available to everyone. For example, if the women, they have to go for smear, they go for pap smear. But we don't think about the equity about it. And this is why, the Northwest Coast, ARC, we've done the focus on research, which is online, our website page. So we need to be looking at both, really, because we don't want to wait for another 10, 13 years to get this right. So my comment really is to say, when we're doing the inequalities, let's focus also on inequity. You know what I mean? I can explain it. Equity, it means ending institutional and discriminatory barriers that lead to inequities and inequality. These include factors within the healthcare system, such as racism, sexism, and as well as factors of healthcare system, poverty. Because if I'm poor, I can't be well. So I think, not to take the thunder from the 2 of you, you need ICS, ICB, and with research, we're doing a lot of research, because I will come back to that, and we've been working with the public as much as we can. Public engagement is hard, I know what you are saying, but I felt that if you want to reduce inequality in that, make sure we get it right now. We need to strive communication between the professionals, hospital, JP, and the social services. An elderly woman going home, right? And she hasn't got all the equipment that she needs. How can she go home? When the ICS is supposed to be integrated care, which means social and health, you're not working together yet. So I will stop there for the moment.
Thank you very much. And we look forward to hearing more.
Thank you.
Jo?
Well, thank you, Dorcas, and thank you both for that fantastic overview. I come as an NHS clinician, and I became interested in health inequalities, having been a paediatrician for nearly 30 years, and realising that whatever I was doing in clinic was just scratching at the surface. I treat children with complex and rare diseases, and many of the medications I prescribe will cost £10,000 or £15,000 a year. And I was sitting in my clinic at Alderhay thinking, this is just bizarre. You know, I'm spending this huge amount of government money on very expensive treatments, and these children don't have enough food to eat. You know, they're not going to school, they're living in healthy houses, their parents are drug users, they can't support them at school. You know, this is completely upside down. And I know that many of my colleagues in paediatrics across the NHS feel exactly the same. You know, the time for us working in isolation and looking at improving healthcare services is just gone. You know, as a group of NHS professionals, as a paediatrician, we need to link up with education, we need to link up with care services, we need to think about the environment. And I think that's what's so exciting about these possibilities, is that we're not working in isolation.
Yes.
And for people like us in clinic, and my colleague here, Shuk, is here from A&E and is acutely aware of the impact of health inequalities. You know, we stand an opportunity of turning the tide, and not living with those frustrations of thinking, what's the point of me giving you growth hormone if you don't have enough food to eat?
Yes.
And I think that's where I come from. So I'm really delighted, and that's what drove us to really link up much more closely with ARC. You know, we're very good in the NHS, so in areas that I work in, at describing inequalities. You know, we know that if you live in the poor areas of Liverpool, you're much more likely to have asthma, you're more likely to be obese, you're more likely to suffer many chronic diseases. And we're very good at describing that, but what we're not good at doing is looking at interventions and then critically appraising them. And that's why, you know, that's why I believe this relationship is so important, because we all bring something to the conversation. And by working together, you know, I think we do stand a much better chance of reversing those inequalities. So thank you very much. I'm looking forward to working together. Thank you.